here with Davinder Grover. I'm very, very eager for this conversation. So we're going to be talking about. I guess this falls within the category of MIGS. It's what sometimes people call MIGS plus. It's I love MIGS. I wonder whether I actually love MIGS more than the actual cataract part of the surgery. But I do draw a line in the sand, and this is past that line for me. So we're going to be talking about micro shunt surgery. So lay this out for me. What do the words I just said mean actually?
Well, first, thank you for having me. It's an honor to be here, and I'm excited to have this conversation. You know, like you pointed to, when classically we think of MIGS, we think of angle surgery, and now there's this new category. Some people are calling it subconj MIGS, but then when we talk about subconj MIGS, and it's actually creating a new drain. So a lot of the angle-based MIGS are opening up a patient's own drainage system, but this is a category of medications where we're creating a new drain into the subconjunctival space in patients who don't have an outflow system that's intact or getting them lower. And there's two broad categories, one that's already approved by the FDA and one that's currently still under investigation. The one approved by the FDA is the Allergan gel stent, Zen 45 gel stent. And the one that's currently under investigation used to be called InFocus, now is called PreserFlow. And those are two just microshunts. And the differences are in material and dynamics, but they both accomplish the same goal, which is creating a subconjunctival filtration.
Yeah, so I'm going to say something dumb that I know that you guys know, but humor me.
All right.
Which is the part of the efficacy, part of the potency of any of these procedures has to do with the pressure head, the difference in pressure between one end of whatever it is you're doing surgically and the other end of what you're doing surgically. And with TM bypass surgery or excision of the TM, the pressure head is between intraocular pressure and episcleral venous pressure. With suprachoroidal surgery, may it rest in peace, it was, for now, it was between the intraocular pressure and the pressure in the suprachoroidal space or potential. This is the biggest pressure difference because it's the pressure between the intraocular space and the outside world. And that's why blebish procedures are so very potent. So I know what the Zen is, although I'd be grateful if you were to review its parameters briefly. I don't know what PreserFlow is.
Well, first, none of that what you just said was dumb at all. It was actually very insightful and a very good way to frame this discussion. So I know you're being humble about it, but that was a very good way to frame it. It is. It's the resistance in the unique component of both of these microshunts is the inherent resistance of the implant themselves. It is open to the world, but it's open to the subconjunctival space. That distal to the implant, once the surgery heals, then you start getting increased resistance, and that can also provide some protection. But what's unique about both these implants, and let's talk one at a time. Let's talk about what's approved. So Zen 45, it's a 6 millimeter long porcine gel stent. The inner lumen is 45 microns. The inherent nature of that material provides a point of resistance and protection against hypotony. Such that assuming a production of aqueous fluid of 2.5 microliters per minute will prevent the patient from having hypotony. And that's Poissier's equation, and I'll pretend I can say it, but I'll pretend I understand it. Now, PreserFlow or InFocus has a similar theory behind it, but there has some other unique features. The material is different. It's called a SIBS material, which is an anti-inflammatory type of material that is well tolerated in the subconjunctival space. It is actually 8.5 millimeters in length, and the lumen size is larger, 70 micron lumen size, creating a similar type of protection against hypotony and resistance internal to the lumen. So they both accomplish the same goal. The features are a little bit different. The Zen can be delivered via an ab internal approach. So you don't really need a conjunctival incision, although there are a group of us now that have shifted to performing the Zen procedure as an ab external approach.
Really?
But the PreserFlow, previously InFocus, must have a prudomy and must be delivered via an ab externo approach.
So I have a bunch of questions. Let me get to the sort of meatiest one first. Um, in comparisons of efficacy of Zen to Trab, um, the postoperative manipulation or I don't know what they called it, if it was procedures for the Zen were sort of highish with a lot of needling going on. Is the idea of an anti-inflammatory polymer, about which I mean I know nothing because I hadn't heard about this prior to this conversation, is that meant to address that hurdle with the Zen?
There's going to be a big discussion and a big debate about my material is better than your material, and this does this and this does that, and I don't think there's much data. I don't think that's going to be. I don't think that's the important part of this conversation. I don't think the material itself, either two, are inherently pro-inflammatory, anti-inflammatory when when it comes to the presence of aqueous. So they've done studies where they've placed these materials not connected to the anterior chamber, just put in the subconjunctival space, and they both are dramatically anti-inflammatory. They do not elicit a strong fibrotic reaction. Aqueous should not be in the subconjunctival space. And when you have pro-inflammatory cytokines and aqueous in a place it's not supposed to be, that's where you get the aggressive fibrotic reaction. So both of these surgeries require anti-fibrotic material. So mitomycin C is what we all usually use to inhibit that potential for skull formation to allow success with these surgeries.
Yeah, interesting. So are the I mean even though one of these procedures is ab um, externo and one of them is uh, uh, not obligate obligatory. There's a word I'm looking for, but that's not what it is. Ab interno. Are they both looking for the same sort of clinical space? I mean, were these are these both aiming for patients in the same clinical context?
Oh, that's interesting. So Zen, they both went to down two different pathways. Zen 45 went down the 510K pathway, which is just a non-comparative prospective study of 65 eyes with refractory glaucoma. Now, in focus, and now Santen is the company that owns this. They went down a different pathway, a prospective comparative trial going head-to-head against trabeculectomy, which I think they should be applauded for because that's a much more difficult task. But they both are aiming roughly at the same type of patients, refractory glaucoma, medical or surgical refractory glaucoma, and but the question you're really alluding to is kind of where all both of these are going to fall into place. Now, this is assuming that PreserFlow it will be approved in the United States, and it's not yet. It's approved in Europe and it's approved in Canada, and so we can use those as maybe a guide mark for what the market may look like or the space may look like once we have both in our hands. And it's hard to know. You know, I have some patients that were both in in the InFocus trial in one eye and the Zen. I put a Zen in their fellow eye. They've actually both done very very well. So it's going to basically be I think dependent on the patient, the features of the eye, the doctor, the surgeon, what they're comfortable with, and I imagine that the hurdle for InFocus is or PreserFlow is going to be a large prudomy, not a huge prudomy, but about a 5 millimeter prudomy. You can do it smaller, but you really have to incise the conjunctiva, and then and that I think will make the doctors think twice on doing that in kind of a milder case.
Right. No, no, no. I understand that totally. I mean, you have an intact conjunctiva with all of the benefits of an intact conjunctiva if you're going ab interno. Um, now, uh, Zen, for a variety of interesting reasons, is also on label for um, standalone use, not just in the context of cataract surgery. It's a little unfair for me to ask you about what the labeling is of a product that's not approved in the U.S. But is it your sense that PreserFlow is going to be limited to MIGS, or is it going to be have that sort of broader spectrum? And this is for the non-U.S. viewers, this is a highly relevant question, not because as physicians we're limited to on-label use, but because we don't want our patients having to get billed for a device because they're generally not covered if they're not on label.
Yeah, well, the labeling has a huge implication in insurance coverage and carrier coverage, but the labeling for both of these surgeries is a standalone. Um, the labeling that Zen was given is for advanced refractory glaucoma. Um, the labeling that the that I believe PreserFlow is aiming for is all stages of refractory glaucoma, not tied with cataract surgery. There are people outside the U.S. now doing both of these because they're not tied to cataract surgery. In the U.S., we're doing Zen and phaco with or without Zen with or without phaco, and I imagine that PreserFlow would be the same thing. We could do it with or without cataract surgery and it not be tied to an indication.
Yeah, really, really, really interesting stuff. I think the part of this conversation that I like best was when you said that you have some patients in which you've done one of these surgeries in one eye and the other in the other eye, and they're both doing well. Everything in medicine should be like that.
Yeah,
It
I
should
wish.
be choices between uh, options that are all good. Um, yeah, no, this is wonderful, wonderful stuff. I learned a lot in this. I learned everything about this in this conversation because I hadn't heard about this, and I want to thank you for getting so sort of granular with this. It's really helpful because it's the details that are ultimately going to dictate, which option we choose. Davinder, most of all, I want to thank you for the generosity of your time that you've spent with me today.
Oh, thank you. This is an exciting time in glaucoma. I don't think the trab is dead, but I think this is a major game changer, and we're going to do far fewer ones. But it's a very exciting time for the subconjunctival space right now. Thank you for having
Marvelous.
me.